the next presenter. Lucy is going to share her screen, hopefully, while I just give a bit of a bio about her. So thank you very much to Dr. Lucy Brooks for being able to be with us today. She's an anaesthetic trainee, currently working as a leadership fellow in climate change and anaesthesia for Health Education England, Yorkshire and Humber. Lucy has a master's in bioethics and medical law and is working towards a master's in sustainability, health and well-being. She's passionate about education and during her fellowship has taught on the topic of sustainable anaesthesia and healthcare to a wide range of healthcare professionals. And most recently, Lucy has been appointed to the Royal College of Anaesthetists Environmental Advisory Group. So I'm going to hand over to Lucy with that amazing bio and looking forward to hearing from her.
Unmute.
That's great. And we can
Excellent.
see your presentation brilliantly.
Perfect. Thank you very much. Well, thank you everybody for having me. This was actually my first slide. I'll go back to it. So for that very charming introduction. My name is Lucy and you've heard who I am. So that's great. We'll crack on. Thank you so much for inviting me today. I think it's really important that I firstly apologise in advance that I don't have very much experience working in low and middle income countries. So if what I talk about doesn't seem to fit in particularly with your practice, I apologise for that, but I do hope that I'm going to be able to give you a flavour of sustainability in healthcare and in anaesthesia, and hopefully that these principles will be transferable to your practice. So this is what we're going to talk about today. We're going to talk a bit about the health implications of climate change and the environmental impacts of healthcare, sustainable value in healthcare and specifically the issues in anaesthesia, and then a bit about what we can do about it, hopefully to inspiring you to take some action. So you might all know this already, but the climate emergency is a health emergency. And as healthcare practitioners, it's our responsibility to tackle this public health issue for the benefit of our patients. And I'm underlining this because I cannot state it emphatically enough. So what about the health implications of climate change? Well, climate change is bad for health. The World Health Organization estimates that between 2030 and 2050, climate change is expected to cause approximately 250,000 additional deaths per year. There's also huge financial implications, with the direct damage cost to health due to climate change estimated to be between 2 and 4 billion US dollars per year by 2030. 2 to 4 billion dollars. It's a huge amount. And whilst here in the UK, some people might feel like the climate emergency is a problem for the future, the impacts of climate change are being felt now in many parts of the world, and some of you may be working there today. So things like drought and flooding and the subsequent impacts this is having on agriculture and food production is causing huge problems. And globally, mass migration due to sea level rising, drought, extreme weather will all increase communicable disease spread as people move around living without permanent shelter or access to medical care. And in the midst of the COVID-19 pandemic recovery, this is something we certainly can't afford to ignore. In fact, the World Health Organization has said that climate change threatens to undo the last 50 years of progress in development and in global health and poverty reduction. I think it's really important when we're talking about climate change to acknowledge that the people who are most impacted by the climate crisis are the ones who've contributed to it the least. Climate change is worsening existing global health inequalities, both within and between populations. And whilst I won't be talking about climate reparations today, I think it's really important to learn about environmental sustainability through the lens of climate justice, by which I mean acknowledging the inequitable outcomes for different people and different places, and striving for fairness in our policy and practices that we use to address the climate crisis. So this increased burden of illness and injury puts increasing strain on healthcare services and on the systems which create the services, which are also themselves susceptible to the consequences of climate disruption. So, for example, damage to physical infrastructure due to flooding and extreme heat can easily affect places like hospitals as well as it can people's homes. So you can see, therefore, how those healthcare systems with the least developed infrastructure and those which are already under strain for whatever reason are least able to prepare for and to cope with the impact of climate change. This is likely to affect services and people in low and middle income countries sooner and harder than in high income countries. But the climate crisis is also an opportunity for us to change for the better. It's important to acknowledge and validate that eco-anxiety is real and quite a normal proportional reaction to the climate crisis. We also have the power to use our voice as trusted healthcare professionals to make positive change in the world together. I think this is just an important point that I want to come back to again and again, which is this is not something we can all tackle on our own. We're doing it together. This slide here comes from the Centre for Sustainable Healthcare. They run courses for healthcare professionals on sustainable healthcare practice and on sustainable quality improvement in healthcare. I'm going to talk to you today about some of the principles that they use, and where you see their logo, which you see here in the corner, you'll know that I've pinched some of their resources. And if what I'm talking about today piques your interest, you can check out what they've got online, and I really would recommend it. But healthcare is not just a victim of climate change, it's also a contributor. Globally, it's responsible for about 4% of total global emissions. So to put this into context, the aviation industry is responsible for 2.4% of global energy-related carbon emissions. It's estimated that if global healthcare sector was a country in its own right, it would be the 5th largest emitter in the world. In fact, the healthcare sector is is the largest service sector in terms of carbon footprint, comparable in size to food sector. In most countries, it's only surpassed in carbon footprint terms by energy, transport, and construction. So this quite complicated graph shows on the left the health carbon footprint, which here is HCF, as a percentage of the national carbon footprint of 36 OECD countries, and on the right as tons of carbon per capita. And you can see there's quite significant variation across the board as to what that looks like in different countries. And I recognise that some of you don't work in the UK, and I hope you will forgive me for using our NHS as an example throughout this presentation. In part, that's because it's the system I'm most familiar with, but also because the NHS was the first healthcare service to break down the details of its carbon footprint into quite great detail. And it's this level of data which helps us to understand where the issues are. And it's a level of data that's not available for many healthcare services around the world, particularly not for low and middle income countries, where until very recently, access to carbon footprinting tools and expertise has been quite limited. In fact, very few low and middle income countries are included in studies on carbon emissions from healthcare. And this table here comes from a paper which I very much recommend you reading by Rashid and colleagues. And it describes how the imbalance is both understandable given the greater relative contribution to greenhouse gas emissions from health systems in high income countries, but also the disproportionate burden of climate change impacts on low and middle income countries. Nevertheless, healthcare in low and middle income countries is a carbon intensive activity, and it's likely to grow with the delivery of commitments to universal health coverage. So this table shows the emissions intensity based on the amount of carbon emissions per dollar spent on healthcare across and grouped by countries' economic classification. So all direct and indirect emissions from healthcare and the supply chain are included in this calculation. And this here suggests that, at least in economic terms, healthcare in low and middle income countries is more carbon intensive than in high income countries. And because many low and middle income countries haven't yet fully met basic needs for healthcare services, there's going to be big investment there. And in 2017, the World Health Organization, estimated that by 2030, an additional $371 billion would be needed to be invested in order to meet the Sustainable Development Goals targets for universal health coverage. And if the carbon impact of this investment follows the average emissions intensity for the 24 low and middle income countries that were using the data that's in this table, the coverage could result in emissions equivalent to an additional 382 million tonnes of carbon dioxide a year. So that's a lot of numbers, but what that means is that we could be looking at a massive increase in global emissions in the region of about 16% increase in healthcare related global emissions. And potentially that could be even higher depending on where that investment is weighted. But if it were weighted towards lower middle income countries, as you can see from this table, the emissions intensity is much higher in that bracket. And so we could be looking at huge leaps in our healthcare related carbon footprint globally. But since universal healthcare itself is threatened by climate change, it's essential that environmental sustainability and emissions reduction is embedded into the development of healthcare services around the world. So where that investment is put, we need to be thinking with our green eco hats on. So in the UK, healthcare is responsible for about 4% of total national carbon emissions. And this pie chart shows you how that splits up between the supply chain and other things. So what this shows is that 62% of emissions come from the supply chain, 24% come from delivery of care, and 10% comes from transport. And this weighting often sort of contributes with the vast majority of emissions in the supply chain, and that's replicated in countries around the world. The NHS was also the first national health service to set targets to have net zero carbon emissions. And the date for the target for this is 2045. So it's coming up quite rapidly. Now, I've mentioned sustainability a few times. The Royal College of Physicians has identified sustainability as a domain of quality, which should run through and moderate the other domains, which are safety, timeliness, effectiveness, efficiency, equity, and patient-centeredness. But healthcare should not only be considered in terms of what can be delivered to an individual today, but also to the population in general and patients of the future. What do I actually mean by sustainability? Well, traditionally, apologies. There we go. Skipping ahead a bit. Traditionally, sustainability has been defined as the quality of being able to continue something over time. And this is particularly in relation to financial resources, and that might be the definition that you're most familiar with. But in recent years, discourse has shifted to include the concept of environmental sustainability. In 1987, the Brundtland Report defined sustainable development as development that meets the needs of the present without compromising the ability of future generations to meet their own needs. And the three dimensions of environment, society, and economy are frequently quoted as being the foundation of sustainability. And these exist in a hierarchy whereby human activities are both dependent on and impact on the environment. The economy can't exist without society, and society cannot exist without the natural environment. So when considering sustainability through this lens, we appreciate the value of things beyond their financial worth alone. And we can understand the need to balance the economy with both social and environmental factors. And this is the concept of sustainable value, which I'll be referring to throughout the rest of this presentation. And we talk about this being called the triple bottom line, so including all three of these aspects. So when we're assessing something's costs and intervention, for example, against its outcomes, we consider its financial, environmental, and social impacts. But what does this actually mean in healthcare? Well, when we apply the concept of sustainable value in healthcare, you can see how a service may be of high quality, but still be of low value if the resources that were used could have provided greater benefit, that's the outcomes for patients and populations, had they been used differently. And this is relevant in all settings, but it's particularly relevant in settings where resources are limited. Sustainable value explicitly considers the environmental, social, and financial impacts in relation to health outcomes, and that's for both patients as individuals, but also populations. Resources are often used as a shorthand for financial costs, but in reality, we are equally reliant on social assets, things like staff, carers, and the patients themselves, as well as environmental resource use. So the goal of sustainable healthcare is to maximise outcomes for patients and populations, to minimise environmental impacts, and to add social value at every opportunity. And this understanding, we can see how sustainable healthcare can be good for the planet and good for people and still be cost effective. In fact, often moving to sustainable models of healthcare leads to saving money and resources through reducing waste in systems. And on the other side of the coin, it's very likely that many healthcare services in resource-constrained environments often are already embedding environmental sustainability practices due to cost effectiveness, such as using reusable equipment rather than single use. The principles of sustainable clinical practice are shown here as described by Dr. Mortimer, and she is one of the people involved with the Centre for Sustainable Healthcare that I mentioned earlier. And they describe how the best way to reduce the climate impacts of healthcare is prevention of disease and therefore prevention of the need for healthcare. So that might look like investment in public health initiatives such as vaccination programs. But where that's not possible, we must streamline care, reducing waste within pathways and within the systems themselves. So that might look like reducing the number of times a patient has to visit hospital, for example, prior to an elective surgery. But what about specifically in anaesthesia? Well, this is the pie chart I took from the NHS, the NHS report on carbon footprint of the NHS. And I've used some arrows here to highlight the areas where there are some sustainability challenges, specifically in anaesthesia and operating theatres. And whilst this is NHS data, I think you'll find the principles are transferable to many other settings, although recognising that the proportions of things may be slightly different. Anaesthetic gases is a big headline. Anaesthetic gases, including sevoflurane, isoflurane, and desflurane, along with nitrous oxide, are greenhouse gases. Waste anaesthetic gases are vented to the outdoor atmosphere virtually unmetabolized, and presently they're not recaptured. So when looking at the impact of these gases on global warming, the NHS has used data relating to their global warming potential, which is the ability of each of the gases to trap heat within the atmosphere. And that varies between different anaesthetic gases. So using this data, when we compare the gases per unit mass, desflurane has a global warming potential approximately 20 times that of sevoflurane, 5 times that of isoflurane, and 10 times that of nitrous oxide. But since desflurane is less potent than sevoflurane, meaning that you need to use a lot more of it to get the same clinical effect, the global warming potential of desflurane in clinical practice is around 60 times greater than that of sevoflurane. And this is shown here on these vaporizers, which are all set to clinically effective doses. The large numbers at the top of each vaporizer are equivalent to the carbon footprint of each of the gases. So you can see here that desflurane has a much higher equivalent of carbon dioxide use per hour at 70 kilos of carbon dioxide, compared with only 2 kilograms per hour when using sevoflurane. You can also see, importantly, that desflurane is significantly more expensive than the alternative gases. And since there's no clear clinical benefit to desflurane over the others, its use does not represent sustainable value. This data has also been used in the UK to drive change to stopping procurement of desflurane, and the current target for that is to stop procurement by 2024. And thinking more on the principles of sustainable value, reducing waste of drugs in all settings, including anaesthetic gases, has both positive environmental and financial impacts. So how can we reduce volatile use? Well, obviously, one option is to stop using volatiles altogether. And that might look like not performing surgeries where they're not absolutely essential, or where you are providing general anaesthesia, to think about using total intravenous anaesthesia, TIVA, or regional anaesthesia where it's appropriate. Although these things do come with their own challenges, and I will come back to that shortly. But when using volatile is necessary, either due to availability of drugs, that's what you have, availability of expertise, that's what you know how to use, or it being the most clinically appropriate choice, using low or ultra low fresh gas flows of less than 1 litre per minute can dramatically reduce the mass of drug used, which in turn both reduces the cost and the carbon footprint. In fact, some anaesthetists practice metabolic flow, where they only provide enough fresh gas to replace the oxygen being used by the patient in a circle system. So this might look like the fresh gas flow of 300 mils per minute on 100% oxygen. And historically, there were concerns about using low flow with sevoflurane due to the risk of nephrotoxicity from compound A, but these concerns don't seem to have been lived out in clinical practice. Other ways to avoid wasting volatile include turning the fresh gas flow off when you're manipulating an airway to prevent the gas that you've built up in a circle system escaping into the room, turning down the fresh gas flows as soon as possible if you've induced on high fresh gas flows, and using a circle system where that's available to you to keep a reservoir of drug in the system and not have to keep continuously be topping it up. And in the UK, it's quite common practice in many places to anaesthetise patients in a separate anaesthetic room prior to transferring them into the operating theatre. But this means that 2 different anaesthetic circuits have to be filled with volatile. So to reduce this waste, we should think about whether or not we should be anaesthetising in theatre every time. And it may be that that's the standard practice where you work anyway, but certainly in many places where I've worked, that's not the case. I mentioned about nitrous oxide also being an anaesthetic gas. Well, when we're talking about anaesthetic gases, nitrous oxide has a few additional things to it. Not only does it have global warming potential, but it also has ozone depleting potential. So it has the potential to both heat the earth and to destroy the ozone. You can see from the graph on this chart here that nitrous oxide has a very large carbon footprint compared to the other volatile agents that I've already talked about. In part, this is due to it being used in much larger volumes than the others. The majority of nitrous oxide use, certainly in the UK, takes place outside of theatres and is usually administered by non-anaesthetists as Entonox, so a mixture of nitrous oxide and oxygen. And particularly this is used in obstetrics for pain relief in labour, but also in pre-hospital settings and emergency departments for analgesia, for procedures and for trauma, etc. So why are we still using it? Well, in part, it's due to poor availability of suitable alternatives, particularly in obstetrics. And in the UK, we've found that we have a lot of wastage of nitrous oxide. So many operating theatres use piped nitrous oxide, which comes from a central manifold of large cylinders. And recent data suggests that we're wasting a huge amount due to leaks from the pipes and the manifold and wasteful manifold management practices, where cylinders that are not empty are changed over. And once the cylinders are removed from the manifold, they have to be returned to the supplier, who then vent any remaining gas into the atmosphere because it can't yet be recaptured or reused. There have also been some reports of theft of nitrous oxide cylinders from hospitals because it's got street value as a recreational drug. But the numbers are quite staggering. In the UK, it's estimated that between 80 and 100% of nitrous oxide and 30 to 40% of piped Entonox bought by acute NHS trusts is wasted before it reaches the patient for use. So this waste isn't only bad for the environment, it's a huge waste of money as well. So we need to look at investigating these leaks and plug the gaps where possible. One way of doing this is to switch from piped gas from manifolds to individual cylinders used at patient bedside. And whilst I'm talking about nitrous oxide, I know that most of the uses by non-anaesthetists, we still have a role to play. And that you can see here on the left, the vaporizers I showed you earlier, which are a mixture of oxygen and air as the fresh gas flow. And on the right, the fresh gas has been switched to oxygen and nitrous. And you can see the dramatic difference this has on the carbon footprint of the anaesthetic. So I did say I would talk a little bit about total IV anaesthesia, TIVA. A study by Sherman and colleagues found the greenhouse gas impacts of propofol are relatively quite small compared to that of desflurane and nitrous, which I have said already, the nitrous and des are significantly higher carbon impacts than sevoflurane and isoflurane. But the calculations they did were quite staggering, saying that propofol was nearly 10,000 times lower carbon footprint than desflurane or nitrous. And this has been backed up and data have been used by Yale to create an app called the Greener Gassing app, which you can download and allows you to compare your real practice as an example in the second point here on this slide. So this data comes from a colleague, Dr. Morgan, who works in Sheffield, and he worked out the average fresh gas flow rates used in their trust at 710 mil per minute, and then input that data into the Greener Gassing app to show how more realistic values of sevoflurane used might compare to propofol. And you can see here it was nearly 120 times higher carbon footprint to use gas than to use propofol to maintain general anaesthesia. But unlike the inhaled drugs, the greenhouse gas impacts of propofol primarily stem from the energy needed to operate the syringe pump and not from environmental releases of the drug. So with this in mind, the energy makeup of a country where you're performing anaesthesia can have a big impact on its carbon emissions, as this will obviously be lower where the energy grid is electricity is produced through renewable methods rather than through burning fossil fuels. So you can often see quite stark differences between places like Australia, where they use very high coal intensity energy, compared to places in Scandinavia where they use a lot more renewable energy. But whether ultra low flow sevoflurane is worse for the environment than using TIVA is a topic of debate, and there are several reasons for that. So the carbon footprinting calculations that are done for drugs only take into account the active pharmaceutical agent, but most of propofol is actually soy-based emulsion, and we don't know where the soy comes from or whether the soy is grown sustainably. And the carbon footprint data used in the calculations in this graph here in the bottom right-hand corner also doesn't take into account the carbon costs of plastic production or disposal, which is necessary for, in terms of syringes, to run them for IV anaesthesia. Moreover, when we're considering this through the lens of sustainable value, we also have to acknowledge that TIVA requires high volumes of single-use equipment like syringes and giving sets, but also it requires expertise, which not everyone feels confident using this, and also not everyone has access to the equipment necessary, such as the pumps, and that the pumps themselves are very dependent on a stable electricity supply, which again, if you're working remotely, might not be something you have access to. And there's also more to sustainability than carbon footprint. I've talked a lot about carbon footprint, and that's where a huge amount of the work in sort of sustainability is focused. But drugs have got other environmental hazards. So, for example, bioaccumulation, molecular pollution with drug and the metabolites. So, for example, if we give our patients drugs, they then metabolize them and pass out of their bodies in their urine, and that enters the waterways. And that may have negative consequences on aquatic ecosystems, whereas that's less of a problem for volatile anesthetics because most of the drug is exhaled unmetabolized. So whilst it's in the atmosphere, it's not in the water. So it's really important to dispose of drugs, when you are disposing of drugs that haven't been through your patient, in the correct way. So in the UK, we dispose of them for incineration, but it's very important that we don't dispose of drugs down the sink as they end up in the waterways and impact on aquatic ecosystems. The other thing to think about, again, is waste, drug waste, and not drawing up more than what will be needed for each patient. So this waste has got both environmental and financial impacts. And think about what you're drawing up. Do you ever draw up a drug that you then don't use? What about your emergency drugs? So common practice in places I've worked would be for anaesthetists to draw up several emergency drugs every day, which they might not always use. And the rationale is that in an emergency, you don't have time to safely dilute and draw up drugs. But an alternative is available in investing in pre-filled syringes for emergency drugs to prevent waste. These are really expensive, the pre-filled syringes, but they can be kept for much longer. So if the syringe isn't opened, you can keep them over time and save both money in terms of not having to buy new drugs every time you draw them up and don't use them, and reduce plastic waste. In fact, there was a trust in the UK that audited this in their obstetric department and found that they saved over £7,000, even though the pre-filled syringes were much more expensive, but they weren't throwing away unused drugs. Another thing to consider, which I think is particularly relevant in all settings, is whether drugs can be given orally rather than IV. Oral drugs have a much lower transport carbon footprint due to their smaller size and reduced weight. They also require no additional equipment to administer, no giving sets, no cannulas. And these may have significant financial savings, partly because the drugs are cheaper and partly because you don't need additional paraphernalia to give them. A team at University Hospitals Coventry and Warwickshire found that if they converted all IV paracetamol doses to oral paracetamol doses in their hospital, there was a potential saving of £50,000 per year, and that they could result in a drop of 25 tonnes per year of carbon dioxide equivalents through reduction in plastic waste and from the medication and the giving sets, etc. So this could be extended to other frequently given IV medications, such as anti-inflammatories, antiemetics. And we should be thinking about giving these orally wherever possible, perioperatively. Now, waste is a huge issue, and it's something that people talk about often. The NHS produces some 4% of the UK's solid waste, which has a huge cost. In the UK, we've got multiple different waste streams, and those which are infectious waste is sent for higher temperature incineration, and that's the most expensive. And this graph is showing that there's a 50-fold impact on carbon footprint through choice of healthcare waste stream. I know not all countries do segregate their waste in this way, but what this is showing is that recycling anything where that's appropriate and possible is the best practice, and certainly much cheaper and better for the environment. But also, the most important thing when it comes to waste and recycling is to just reduce the amount of waste being produced in the first place. So ensuring we don't open things that we don't need, not wearing disposable gloves unless clinically indicated, and using reusable equipment. This chart gives some of the environmental profiles of reusable versus disposable LMAs. And clearly, the reusable have a much more favourable profile, and it's cheaper per use in the long term. But unfortunately, reusable LMAs are no longer used in the UK due to concerns regarding CJD transmission. But a lot of these results are reproducible across many different consumables, such as surgical gowns. In fact, this is one of the ways, as I mentioned earlier, that often countries where the more resource-limited healthcare settings will be already using reusables because they're cheaper per use over time, rather than a disposable kit. And that's where, again, sustainability and environment and financial benefits go hand in hand. I've talked a little bit about energy already. Well, operating theatres are 3 to 6 times more energy intensive than the rest of the hospital. Most of the anaesthetic equipment has relatively low power consumption, but we do have a few energy hungry pieces of equipment. I think that we also need to acknowledge that we're in a very privileged position here in the UK with having very reliable energy sources, but fossil fueled emergency generators are found in hospitals worldwide. And in low and middle income countries, unreliable electricity grids often leave facilities dependent on these expensive and very polluting generators. So where grid power is available, it also might be more carbon intensive in low and middle income countries than in high income countries. There was a report in 2017 that found that each unit of grid supplied electricity resulted in 743 grams of carbon dioxide equivalent in India, compared with the average of 303 grams per unit across the EU states. So investing in off-grid solar energy might be a solution, and these have lower running costs than petrol generators, with less air pollution and fewer carbon emissions, as well as less noise. Now, I really like to talk about perioperative care. I think perioperative care gives us loads of opportunities to apply the principles of sustainable healthcare in practice. There are so many things to think about and that I could list, but I'll briefly mention a few ideas. As anaesthetists, we have to make every contact with our patients count by promoting healthy lifestyles. So that might be offering smoking cessation support or encouraging vaccination. We should also use contact with our patients to improve their own healthcare literacy and empower them to seek healthcare at the most appropriate time. So not sitting on something that is going to become more of a problem if they don't seek healthcare early. We also need to plan lean perioperative services. So, for example, avoiding unnecessary preoperative testing. There have been several audits published documenting how frequently unnecessary pre-op blood tests are performed in the UK. So one study found that it was nearly 70% of tests done preoperatively were unnecessary and didn't meet the NICE guidelines, which is a huge waste of money and causes avoidable harm to the environment and avoidable harm to the patient. If you have to attend your hospital appointment, that costs you time and money and time off work, and physical harm, in terms of having a needle stuck in you potentially unnecessarily. I imagine that in more resource-constrained healthcare settings, this type of unnecessary testing is a lot less frequent for reasons of financial cost. And again, this highlights the overlap between cost effectiveness and good care that's good for the patient and good for the planet. Another thing we can think of to streamline services and reduce waste is to look into the pre-op setting and what a one-stop clinic might look like. So patients could be seen by surgeons, have all their pre-op testing, see anaesthetists all in one go, rather than having to come to the hospital multiple times. Again, it's cost-effective hospitals and patients, again, for not having to take time off work, not having to pay for travel. And that again adds to social value. An alternative is to think about conducting reviews by telemedicine, where the infrastructure is in place to support this. Telemedicine can add huge sustainable value through its social benefits, so increasing accessibility for patients, particularly those who live remote from healthcare services. Overnight stays in hospital are associated with carbon emissions, for example, due to the energy used to care for them, and to the energy needed to the food needed to feed them. So planning day case surgery where appropriate is another step towards sustainable surgical pathways. And where we can't streamline services, switching to lower carbon options, as I mentioned about reusable things both perioperatively, in theatre and afterwards, is helpful, and reducing waste of medication, switching to oral medication as soon as possible post-operatively. And what about travel? So in 2017, NHS travel was responsible for 9.5 billion road miles, which equates to 3.5% of all journeys in England, which is absolutely huge. And this resulted in around 7,285 tonnes of nitrogen oxides and 330 tonnes of particulates, so air pollution. And this is causing a huge amount of air pollution, which we know contributes to deaths and unavoidable deaths due to air pollution. In fact, by some estimates, 1 in every 20 journeys in the UK is healthcare related. And according to the Royal College of Physicians, 40,000 people die every year from air pollution in the UK. So could all this travel be related to all these deaths be related to NHS travel? Increased mortality is also due to travel is also costing us a huge amount, estimated at £345 million. The staff commute is about 4% of the NHS carbon footprint. But on the other hand, the UK is the first place to have created net zero emissions ambulance, which has recently been launched. In fact, it was launched at COP26, so not that recent anymore. However, there's large costs associated with replacing vehicles in the healthcare fleet. In low and middle income countries, vehicles may be older, public transport options are often more limited, and that exacerbates accessibility for remote communities and makes it very difficult to reduce the carbon footprint of healthcare related travel. Oops, sorry. Yes, but travel is particularly relevant to those of you who are undertaking international training programs. Aviation, as I mentioned before, is responsible for 2.4% of global energy-related carbon emissions. So I think there's an interesting discussion to be had around the role of healthcare professionals in improving health. How do you weigh up the good that comes from international partnerships which help develop healthcare in low and middle income countries with the aim of improving health outcomes for people and for populations, and balance that with the harms done by climate change attributable to air travel? I don't have the answer. But I generally follow the principle of first do no harm, by which I take to not only mean the patient in front of me, but also to the patients and populations that are not known to me. So I'm going to leave that for you to have a think about and how that balances up in the work that you're doing. But what can we all do? What can you do in your departments? Well, I've talked about a huge number of things today. And as I say, I hope that some of these things will be relevant to your personal practice. There are loads of actions that we can take as individuals and as anaesthetic departments, but we also need to recognise the needs of governments to put in strategies to reduce carbon emissions, and to think about making sure that healthcare services are resilient to climate change. But that doesn't mean we shouldn't do anything as individuals. So think about what you can do to reduce the environmental harms caused by healthcare and to add sustainable value into your services, as I've described. Think about what actions you can take as an individual. As healthcare professionals, we say we will first do no harm. And we've got to take this beyond the patient in front of us and apply it in a much wider sense. So recognising that our environment is intimately connected to our health. And this responsibility extends beyond our clinical roles. I think that as global citizens, we have a responsibility for the planet, and we have to do our part towards improving the climate change and towards social justice. And these things come hand in hand, as I've already described. So there are a few examples here. Again, this comes from the article I recommended in the BMJ by Rashid and colleagues, looking at examples of decarbonisation projects in low and middle income countries. And there really are people doing this work all over the world. And these examples are not specific to anaesthesia, but as healthcare professionals, we need to use our voice across the healthcare service and beyond to make change happen. So here you can see people have done things like installing solar power to power the hospitals. And again, that often has huge social impact by being if it's local to the hospital, we don't have to worry about grid interruption supply, which can be very helpful to local communities as well as to the hospital, the communities where the hospital is situated, to have regular supply of electric. Thinking about carbon reduction programs, so things like switching the type of air conditioning that may be used in the hospital, switching the type of lighting that's used in the hospital, for example, switching to LED lights, which are last for longer. So that's, again, a financial saving, and are better for the environment as they're lower energy. So there are a huge number of things that can be done. And I would really recommend reading this article if you're interested in any more of them. So I've done a lot of talking. And what I'd really like you to think about is what action you're going to take towards sustainability. So I think it's really important to sort of harness the energy. If what I've talked about has inspired you to think about this in a way you haven't done before, take a minute to think about what you're going to do and write it down. Set a review date in your calendar to hold yourself to account, because it's really easy to go to talks and go to conferences and say, oh yeah, I'm really interested in that, or that was a really interesting idea, and then you go home, you get on with your life, you feed the kids and think about what you're going to do tomorrow at work, and this stuff slips into the background. So don't forget about this. Please put this in your calendar and review what you personally are going to do. I've got a list of resources. There's some here. I'm not going to keep this up for long because I'm really conscious of time. But there's lots of other things that I can point you in the direction of. Please do get in touch with me. You can share my email address with you, or you can find me on Twitter, and I can share this with you, or through the conference organisers if they're happy for me to do that. So that just leaves me to say thank you very, very much for inviting me, and for letting me join you today as a bit of an interloper. And I'd be very happy to have any questions or comments or anything that you think stood out to you, or anything you think I've really missed the mark with. I'd really like to know. So I'll open it back up to you guys.
Oh, thanks so much, Lucy. And definitely not an interloper, just giving a different perspective on things. And I think it's really, really interesting. I've learned a lot, actually, because we have anaesthetic rooms, and I suppose I've never thought about that as a risk in itself and something that increases your carbon footprint. And I don't know, I wonder whether we could get rid of them in the future, but it's your sort of mecca of calm, isn't it, the anaesthetic room? And in Zambia, they don't have anaesthetic rooms, so at least that isn't part of the problem. But one thing I would say is that the difficulty is we have reliable gas monitoring, so we can use low flows, and this is where low and middle income countries will really struggle to try and reduce their uses, because they're trying to make sure the patient is asleep with one hand, but trying to help the environment with the other. And if you don't have the right monitoring, that'd be very difficult. But hopefully in the future, they'll have a slightly more reliable monitoring for that. But as a charity, we are looking at our carbon footprint. And like you say, we've turned during COVID to remote fellowship, and that's still ongoing. And hopefully that potentially reduce the number of flights that we use. And we look at it on balance to see whether we think it's still sustainable and useful to the countries that we're in to actually do that travel, because like you say, it's a massive impact on the environment. And from your perspective, what do you think is the one thing that you've done that's had the most impact, or that you found the most interesting?
I think that it's about lots of little things. I think one of the most important thing is to be thinking about this. So I think before I really started studying about this and learning about this and working in this field, I really hadn't thought about the concept of value, and in any other sense than financial value. And I think particularly in healthcare, as in the NHS, but I would imagine low and middle income countries too, it's very much about how much can we get for this bit of money, and how and understanding that the actual value of that is more than just the dollar sign, and trying to input thinking about every decision through that lens of sustainability from a triple bottom line perspective. And I think that's the thing that has really changed. So when I'm thinking about doing quality improvement work, I'm thinking about value from across the board. And when I'm thinking, for service development and service change, again, it's not just about money, but actually, as I hope I've showed, that the hand-in-hand benefits of financial savings often come with stuff that's more environmentally sustainable through reducing waste in systems. And I think that's the thing that has changed most for me. So thinking about that in everything I do, and particularly thinking about waste in systems, I think perioperative care is kind of the next big thing for me, thinking about what are we doing that is wasteful in the services we provide. So I'm not talking about how much rubbish we make, although that is a part of it, but also how often are we asking our patients to come in? What can we do to promote good health? The best thing we can do, and the best thing we can do, both from an environmental and a cost perspective, is to engage with public health, which I think is something as anaesthetists is not really our bread and butter, but it's the thing that we can do that's going to have the biggest impact and be best for our patients, because patients are going to be happier when they are healthier. So it's got all of those things, both environmental, financial and social value, to engage with that public health discussion.
Yeah, and you mentioned patient empowerment as well. Controversially, I wonder whether, because we obviously have a national health service, so there's no financial implication to people coming to the emergency department or coming into hospital, and maybe looking at other countries' models, it might reduce those visits to hospital, therefore reducing the cost, therefore reducing and having an environmental impact as well in the long term. So I don't know, I just wonder whether some of it's, we take things a bit for granted when it's free service.
I think so. And I think that there's something to be said about health literacy being really important across the board. So yes, I think you're right that for people of my generation who've grown up in the NHS and have never had to pay for my healthcare in this country, which I'm very, very grateful for. And that's something that is a privilege for me. And I think that for a lot of people, it is easy to take that for granted. But also some of it's to do with, in both here in the UK, but in all countries, health literacy. And where, I mean, that obviously partly stems from literacy, as in reading and writing as well, but health literacy and understanding when is the right time. So we often get people who come to meet our services who might not need to come yet. You know, they've got a problem that they could have self-treated, and we need to empower people to self-treat where it's appropriate. So not present for absolutely everything. But also we need to empower people to present early and at the right time for some conditions. You know, it's going to be much, much cheaper and better for the environment, much less healthcare intensive to treat your cancer early. So it's about, how do you engage with communities in a way that is meaningful to them, to make them understand when is the right time and how to keep themselves as well as they can, but still not to be afraid of seeking out health services. And I think that in this country, very few people are really afraid to seek health if you're born and bred here. But we've got a big problem in this, you know, in the UK with refugees and immigrants seeking health service for fear of what that's going to do for their documented status and that kind of thing. So again, it's about, how do we make healthcare accessible at an appropriate time to hard to reach communities? And that's both remote in terms of physical distance, but also remote in terms of healthcare literacy and engagement. And I think that's a really difficult thing to do.
Yeah, and that fits in with other countries in the remote side of things.
Yeah.
Education underpins everything, doesn't it? But it's how you get that education out to the remote and rural and to the countries that need it, not just ours. There's a question in the chat box. You talked a bit about using reusable equipment, and it says, I wonder whether now is the time to campaign to stop of using disposable equipment such as laryngoscopes, bougies, etc., on the grounds of such a remote risk of CJD. And I mean, I started anaesthetics training and we reused the LMAs, and we only threw them away if it was if there was anything that would risk CJD. So do you know is there any move to maybe think about that, or anything that you would agree with?
Yeah, I think that in kind of sustainability circles, there's people are calling for it. It's really hard. CJD is an example, but we're finding that it's interesting. Often I think people quote infection prevention or infection control as a reason for all sorts of things, but very frequently for the use of disposable equipment across the board. And I think that sometimes that is valid, but often it's just through lack of discussion with people who actually know what they're talking about. So I think that, yes, it's definitely a discussion that's worth opening. I'm not a microbiologist. I don't fully understand the risks around CJD, but also we know that we did used to use reusables. They use reusables in lots of other countries, and how much CJD is there. So my kind of common sense brain tells me this is something we need to be re-looking at. But I think there's other things that are perhaps less controversial than CJD, things like disposable glove use. I mean, when I worked in quite a remote hospital in Mongolia, I remember seeing the nurse there washing her gloves. And that was something I hadn't seen before, because in the UK, everyone would just put on a pair of gloves, throw their gloves away. But that kind of people using gloves, it's because we have such a kind of 1 a penny, 2 a penny about gloves here. And that's something that actually I think there could be much bigger impact. And you might have seen the Royal College of Nurses did a gloves are off campaign about only using and only wearing gloves when there's a clinical need. So gloves are to protect the wearer, not the patient, or non-sterile gloves. And non-sterile gloves are not as clean as clean hands. So again, talking to people about appropriate hand washing and hand hygiene and removing disposable gloves is actually probably a much more accessible and easy kind of a disposable issue to tackle than the reusable LMAs, although I do think both are extremely valid. But yeah, I think we should all be campaigning to go back to reusables. One thing I didn't talk about, which from an environmental in sort of side of things is interesting when it comes to reusables, is that it feels like that reusables will always be the answer. And that's not necessarily true. So the kind of environmental cost of reusables comes from the sterilization process, and that's very water heavy and very energy heavy. And so it depends a lot on what mechanisms of sterilization are used, but also what the energy grid makeup is. So again, somewhere like Australia, where they're coal heavy, the carbon impact of sterilizing stuff is huge compared to somewhere where they use renewable grid energy. And also cost, if it's an item that you don't use very often, then actually the cost of reusables is often more expensive per item, and it only becomes cheaper per use if you use it frequently. So something like LMAs is a really great example because we use them all the time, but some fancy piece of surgical equipment that only gets used once in a blue moon might not be the balance might not be the same.
Great. Thank you very much, Lucy. That's really, really insightful, and definitely, hopefully we've all got a bit of food for thought for how we're going to adapt our practice and set some goals and deadlines for things.